A very good evening and welcome everyone. I, Dr. 𝗗𝗜𝗓𝗘𝗘𝗣, on behalf of Voice of Healthcare, welcomes all the speakers and the viewers who have joined in for today's discussion, Relax and Rethink, Controlling Diabetes by Decoding Sleep and Stress Cycle, organized by Voice of Healthcare in association with Fitterfly. With this discussion, we aim to understand diabetes distress and the role of sleep in managing it. I would like to commence this session by introducing the speakers for this discussion. Dr. Sanjay Kalra, Endocrinologist, Bharti Hospital, Karnal. Welcome, Dr. Kalra.
Thank you. Thanks.
Dr. Tejal Lathia, Academic Advisor, Fitterfly, Consultant Endocrinologist, Apollo Belapur, Fortis Hiranandani Hospital, and Cloud9 Vashi. Welcome, Dr. Lathia. Ms. Neha Verma, Clinical Psychologist, Head Department of Psychology and Wellbeing, Fitterfly. Welcome, Ms. Verma.
Thank you.
I welcome Dr. Nilesh Bhandari, Vice President, Physician Partnership, Fitterfly, to lead this session from here. Over to you, Dr. Nilesh.
Thank you, Ritika. So, given it to humble me now to take it over with Dr. Kalra, Dr. Tejal, and Ms. Neha. Thank you. So, before we start, I'll just I'm putting a small audience poll for the doctors in the audience, just to get a background of what their views are on sleep and stress. So, the topic of the program today is how do sleep and stress actually affect diabetes care, and do they really have an effect? So, I'll just put up the poll once if you give me a second so that we can continue with this after that. Yeah. So, thank you. Dr. Kalra and Dr. Tejal, I'm a doctor and I practiced for years and years now, decades now. But I never really understood. Before we started discussing this topic, I never really had any idea of stress and sleep actually playing a role in diabetes. And I didn't even know if patients would ever come to you with this question, I feel stressed while taking care of my diabetes, or I don't sleep well while taking care of my diabetes. Is this a common occurrence in your practice, Dr. Kalra? Is this a common occurrence? Patients come to you and complain about stress and sleep?
It is quite common. So actually, Nilesh, what happens is in traditional medicine, you tend to follow a Newtonian physics kind of a model, a binary model, cause and effect. So in acute medicine, you have something like a mosquito bit me, that caused malaria, then I got fever. So it's a linear kind of a thought process. And then to
Right.
come back, I will take an anti-malarial that will kill all the the malarial protozoa, and then I'll become okay. We sort of, extrapolate this to chronic disease. So in chronic disease, the same thought process would be, I have insulin deficiency or I have insulin resistance that causes high glucose levels, that causes diabetes, which causes complications. How do I fix it up? I just take insulin or tablets that corrects my high glucose. It prevents me from getting complications. I feel healthy. This is a linear thought process. It's something similar to Newtonian physics. But let's look at the field of physics now. Newtonian physics is there. It is part and parcel of science. But then they learned something called quantum mechanics. And in quantum mechanics, what they learned was that energy is equal to mass. So suddenly you have, right now you have mass in front of you. Suddenly it disappears. But it's not disappeared. It has just got converted into energy. And then the energy can get reconverted into mass as well. So people began expanding the ambit, the horizon of their thinking. We have been doing this in diabetes as well. From a biomedical perspective, we've moved to biopsychosocial. So multiple things going on at the same time. And instead of these linear thought processes, now we have complex thought processes. Just as an example, instead of us saying that it is the malarial protozoa which causes malaria, we'll say, of course, there is a protozoa, then there is a mosquito, but then there is poor sanitation as well. There is poor health accepting behavior. We don't keep our surroundings clean. So everything is contributing to malaria, right? In diabetes, we'll say it's not just insulin deficiency or resistance, it is defronzos octet. Let us move one step ahead now. From Newtonian, we move to quantum. And now this year, the Nobel Prize was won for something called entanglement, quantum entanglement. Exactly the same thing happens in diabetes. We call it endocrine entanglement. Everything is all mixed up together. So you cannot differentiate, you cannot separate biomedical from psychosocial. It's all together, it's all entangled. And sleep and stress is important. So now,
Right.
so far, we've been discussing at a macro level. Let's come to a very basic level now. When you go to sleep, there is a different level of hormones in the body. When you wake up, there is a different level of hormones. This is well known, the circadian rhythm, whether it is growth hormone coming from the pituitary, or it is cortisol coming from the adrenal gland, or testosterone coming from the gonads. All of these vary with the time of the day, with the time of the night. All of these are influenced by quality of sleep as well. And when there is so much of change in these hormones, it would stand to reason that there is change in other hormones as well. Some of the hormones we've spoken about, cortisol and growth hormone, adrenaline, another hormone which increases on waking up and reduces on sleeping, these are known as counter-regulatory hormones. Counter-regulatory means they counter the effect of insulin. So if these hormones are normal, their impact on insulin will be normal and you will probably have euglycemia. But if these hormones get upset, and they may get upset along with or because of disturbed sleep. So they can be a consequence of disturbed sleep. They can also be a cause of disturbed sleep. And they just might be a confounding factor or they might be a concomitant picture. When all this happens, certainly one thing is going to happen. So you can debate upon what is the cause, what is the effect, but certainly one thing is going to happen. There will be an impact on insulin sensitivity. And once this happens, obviously there will be an impact on glucose metabolism. And that is why our patients do come to us. They come and say, yes, I am getting troubled. And then sometimes, it helps. Tejal is an expert in this. She's the communication expert of India. And Neha knows the psyche of the patient. But, patient will come and tell you, doctor, last week I did the same thing that I did this week. I ate the same food. I did not do the same exercise. Yet last week my glucose was 100. Now this week the fasting is 200. So then when you dig into the history, then you find out that sleep disturbance might have caused the alteration in glucose levels, the variability.
Thank you, Dr. Kalra. In fact, we already have feedback from somebody called Shibu Nair in the audience saying that quantum entanglement in medicine is a new information for him, and thanks for sharing. So you did make us think much deeper than what we thought about of diabetes and insulin and adrenal gland hormones, and we had a very myopic view of the whole thing. So, Dr. Tejal, what's this? How often do people actually think of these things in your clinical practice? Do your patients mention stress and sleep as a common occurrence?
So, Dr. Nilesh, I'd like to separate the two. Stress is very often cited as a cause for high blood sugars, but sleep as a cause of high blood sugars is usually not what people come to us with, because they don't understand that there's a direct relationship between sleep and blood sugars. But that is something we often pick up when we're talking to the patient. So I'll give you an example that if somebody is on insulin and they take bedtime insulin every day, and we find that they're eating the same food, taking the same dose of insulin, and everything is same, but you find that on some days of the week the fasting blood sugar is high, and on some days of the week it's absolutely normal. And sometimes when I ask the patient, was there any problem on Wednesday night, did you not sleep well, and they'll say, yes doctor, that day I didn't sleep well. So a lot of times we can see the direct reflection of the quality of sleep and the quantity of sleep on the blood sugars. But that is a short-term association. And then, of course, in the long term, prolonged periods of poor quality sleep, poor quantity of sleep will then, of course, contribute to worsening of glycemic control. It adds to cardiovascular disease and so on and so forth. I would also like to point out that though people say that, doctor, you know what, I was very stressed and that's why my sugar is high, but there are different connotations of the stress as well. So of course it could be directly the emotional upset or anxiety or worry which is causing the sugars to go up, but also when you are stressed, the coping mechanism that you use to take care of the stress also differs. So I'm sure that Dr. Neha will talk about this, that a lot of times when women are stressed, men are stressed, they tend to eat more, they tend to eat sugar, they tend to crave sugar, they tend to eat the wrong foods. A lot of men take care of stress by drinking alcohol, by smoking. So it's not only the direct relation of stress with blood sugar, but the coping mechanisms that are used to manage the stress, that also has a huge impact on the glycemic control.
Thank you, ma'am. And in fact, I have some live data supporting what you just mentioned. So when we had asked in the poll about how often do your patients mention stress and how often do they ask for medication, so we had a much bigger response for the stress question, in which 75% of the doctors said that sometimes their patient talk about stress. 12.5% said never, and 12.5 said often. So this was a much bigger poll, much more doctors mentioning stress as a factor mentioned by their patients. Whereas on the other hand, there were just 3 doctors who answered about the request for medication for insomnia, but all 3 doctors said that sometimes their patients do ask for medication for insomnia. So it does seem in the real-time poll that stress is mentioned much more often than insomnia in their practice. Going on, we have something known as diabetic distress score, or a DDS. Neha is with us. Neha, could you tell us in more detail about DDS? What is diabetes distress as such?
Sure. So, diabetes distress has everything to do with stress that you face while you have diabetes. It can be with the beginning where you are diagnosed with diabetes, or the entire process of managing the disease. So, it's about the intensity of emotional distress that is associated with managing diabetes, or definitely with its diagnosis, especially those people who are diagnosed at an early age, who do not really expect something like this to happen. Over there is a very high emotional burden which they carry with themselves when they talk about the stress related to being diagnosed with diabetes, and this is regardless of type 1 and type 2. And then comes the basic the regimen which they have to follow once they've been diagnosed with it, the various things, activities, and managing diabetes, for which they have to do constant blood glucose monitoring, or making healthy food choices, or maybe even sticking to a diet plan and following it, being very regular with their exercise routine, adherence to medication or insulin that they are put on, tracking hypoglycemic symptoms, and following a self-care regimen. All of this becomes very overwhelming. So DDS score, as you said, is a scale, diabetes distress scale, which measures diabetes distress among patients with diabetes. And it assesses the extent to which it has emotionally troubled you, and it is causing enough stress in your mind, not making you concentrate and affecting your focus in your daily activities. It also starts impacting your relationships to a certain extent. So there is something called interpersonal distress, which we assess through it. Then there is regimen distress. So all these things that I said one needs to follow in order to maintain a good self-care regimen for managing diabetes. That also becomes troublesome. And then the cost involved in medicines and the possibility of developing various other diabetes-related complications again add the burden to it. So there is definitely a need to assess or screen patients for diabetes distress whenever they are diagnosed with it, because it does play a very important role in the management of the disease. And even research supports the same, saying that higher diabetes distress is associated with poor self-care behavior and subsequently leading to poor management of diabetes.
Thank you, Neha. In fact, I have some data from a study conducted by you some time back. Uh, could you explain this data which was shared with us, Neha? Could you?
Right. So here, as you can see, we analyzed this amongst 861 patients who were diagnosed with type 2 diabetes. And as you can see, these are the 4 or 5 parameters which are assessed through the DDS scale. Emotional burden is the extent to which emotionally you're feeling burdensome with respect to meeting the demands of the disease and the diagnosis. So 58% people had high emotional burden. Physician distress is more to do with the satisfaction of the treatment that they are seeking from the doctor that they are going to. And this is related to the communication pattern and the time spent by the doctor with the patient and the concerns being addressed. And a lot of times we've identified that people or the patients are not able to communicate what they are feeling properly to the physicians, and that is why their physician distress is high, and not because the doctors are not paying so much of attention. So a lot of interventions are required over there to make them understand how in less time you can actually communicate whatever you are experiencing, so that the treatment is planned accordingly. So 29% of such people had high physician distress, and 53% had high regimen distress. So out of my experience, I've seen that people know what they have to do to manage diabetes. They've been suggested various things, but fitting all of that into their daily routine with various other responsibilities and priorities that they have becomes challenging. And that's why maintaining that regimen becomes stressful. And last is the interpersonal distress. So a lot of times we seek support from the family. It could be your spouse or your children, where you need people to understand what it takes you to manage a disease like diabetes, and you need that support. You need people to understand, you need people to support you, you need people to sometimes even push you and motivate you to stick to a strict regimen, and even help you out with it. So over there also 28% people seem to be lacking that kind of adequate social support, which is further adding to the overall diabetes distress. So in a way, 42% out of the 861 have overall high diabetes distress.
Right. So, Neha, what I see is the whole burden with having the disease, managing diabetes, following the regimen is the major part of the distress. It's less
Yes.
to do with interpersonal and physician distress. It's more to do with handling the whole disease and the regimen to follow with that. So, excellent data that you collected, Neha. We have other questions that we have to go to, but I already have incoming questions from doctors in the audience. So, I would like to take it up right now because it is very initial question that should be answered right now. So Dr. Shubhang Gupta on LinkedIn and Dr. Jyotsna on YouTube, both of them agree that this is a very important topic and patients don't talk about this. Their question is, how do we actually reach out to these patients and get these points out? What kind of questions do we ask them? How do we actually elucidate this point from patients about stress or sleep issues? How do we enter this topic? Dr. Kalra, we'll start with you.
So it's best to ask. If you don't know, you ask. It's just about how you ask. So in general, uh, try to be soft, be polite, and maybe something like, "Is there anything else I can help you in? How can I help you more?" That's one way, a general way. Another way which I found useful in my OPD is you begin by thanking the patient. So a typical conversation might go like, "Thank you so much for taking this huge, big size tablet of metformin. I know how difficult it must be to swallow it. Is there any other problem that you face while you're managing diabetes apart from swallowing this big size tablet? Or you have been advised 3 injections of insulin a day. I know it must be tiresome for you. Is there any other way I can help you?" Supposing you get nowhere, like today, my last patient in the OPD was a patient with depression. He certainly fulfilled all the diagnostic criteria for major depressive disorder. But the reason was poor glucose control and the proliferative retinopathy. He had got macular edema and he couldn't see properly. That's why he was depressed. So I was trying each and everything, in the book to get him to open up. He just refused to speak. He refused to smile. All the talking was being done by his relative. So then maybe another way would be, "Thank you, madam, for taking care of your husband. Uh, how easy, how difficult is it to cook healthy food in the clinic, in the kitchen?" That's another way you get people to open up. In management, this is called fishing. You just keep on fishing for an opening until you get one. And
Right.
here, finally, what worked was, so I asked him in Hindi, "Ghar wale tang to nahi karte? Do the people at home trouble you a lot?" And then he opened up and he said, "Yes, they trouble me a lot." "So how do they trouble you?" "So, they don't let me eat food. I want to eat sweets. They don't let me eat sweets. They're nagging me all the time." And then I said, "Doesn't matter. I mean, the rules are with us. So if these are the things we can do, then we found a middle path. Don't take gajar ka halwa that is cooked in ghee, but you can take gajar ki kheer without sugar that is cooked in milk." So we talked about the Hindi, the difference between kheer and halwa, and then a slight smile came to his face. And then I said, you can take as many fruits as you want, but make sure you take them in small plates. And if you want to take 2 kg of apple a day, you are welcome to do that. Just you divide it into 12 different parts. So even I know he's not going to take apple every 2 hours, but the tone was like that. So keep on fishing, ask the patient, and try to find an opening. I think once you are able to convey a sense of and Tejal, I learned some new English last week, so I just have to share that. So sympathy is something that we are all able to share. From sympathy, you move to empathy. Empathy means being able to put yourself in the other person's shoes. But इसके ऊपर एक level होता है, that is called compathy. Compathy means being able to put yourself in the patient's heart. So once you're able to convey through English or Hindi or Bhojpuri or Marathi that you can understand what is going on in the patient's heart, that is compathy, then the doors will open up. And that is the stumbling block. If you are able to, that is the limiting factor, the rate limiting factor. We were talking of equations also in science and physics and chemistry. Once you're able to overcome that, you will find that the doors will open and actually you will achieve glucose control.
Dr. Tejal, your views. How do we fish out? How do we fish for these conditions in our patients?
So, of course, one of the challenges is, I think what most doctors will agree, is that often there isn't enough time in the clinic, to really, and we feel bad about it. It's not like we enjoy doing it, but if you have a list of 30 patients, sometimes it's difficult to get into the nitty-gritty with the patient. So one of the things that you could do is, you have a diabetes distress scoring there in your reception, and while the patient is waiting for you, you could get them to fill the diabetes distress score. And then when they come into you, you know what area is troubling them the most. And then maybe you could specifically ask questions about that area. But I do have time with my patients because I see very few patients a day and I schedule it that way. So I have more time for my patients. And one of the things I've realized is that whenever somebody comes with high blood sugars, even before giving the person a chance to tell us about why the blood sugars are high, what I would usually do in the past is, आपने पक्का कुछ तो खाया होगा, आपने डाइट फॉलो नहीं किया होगा, आपने एक्सरसाइज नहीं की होगी, या तो गोली मिस कर दी होगी. ये हमारे 3 पेट आंसर्स है to account for high blood sugars. And a lot of times in the past, I would not consider that there could be more factors beyond just diet and exercise and medication non-adherence, which could contribute to high blood sugar. And patient would swear themselves blue that, no, I promise I've been doing my diet and exercise. I swear I've been taking my medicine. I don't know why the blood sugar is high. And then if you give them a second pause, like Dr. Kalra said, and you give them that space where they feel comfortable and they feel able to share with you, then they would come up with some of the things that trouble them. I remember one of the most poignant moments in my clinic where, I did the same thing. The sugars were high and I said, aapne ye nahi kiya hoga, wo nahi kiya hoga. And she said, you know what, my husband died. And that's why my blood sugars are high. Because it was extreme psychological distress. She forgot to take her medicines. She didn't care whether she lived or not, because she had such a big tragedy in her life that the diabetes just took a back seat. And it was this loss which was center forward. So I think, one, by routinely screening for people for diabetes distress, if possible, in your clinic. But second, not assuming that it is only diet and exercise and medication which are responsible for high blood sugars, and giving people space to share beyond these 3 usual culprits as to what is troubling them and what is adding to their blood sugars.
Got it.
If I can add, Nilesh, what Dr. Tejal is saying is right. Don't be judgmental, and do not, like you said, myopic. So look at the larger picture. The first few questions should be, how can I help you? Kya ho gaya? Sab theek hai kya? All well at home. These should be generic questions, not linked only to diet or to exercise or to sleep. Let the patient come out and speak, and you follow the patient's lead. There is another skill that I've picked up from coaching. The first question should never be kyun ya why, though that is what we are trained to do in medicine. The first, you can ask the same question, it just has to be rephrased as how. Instead of saying, why did you eat the ice cream? All you have to do is rephrase, what's going on in your life? How can we help you? How can we find ways of resisting ice cream? And this thing about the patient presenting with a tragedy, this has happened to me also in the past. And then you feel so bad, you feel so small inside. You wish as if, the earth would open up and you could hide under the table or something. So with time you learn, and it's a good idea not to be judgmental, just to ask the patient. And you trust the patient. Finally, he or she is in charge of their life, and you cannot, force the patient to follow what you're saying. Just do it. Another point which Tejal said was about screening. So we use something called the 𝗗𝗜𝗦𝗘𝗘𝗣, which is an India-developed evidence-based tool. Instead of talking about distress, we are talking about coping mechanisms. How do you cope? And that gives a positive attitude, a positive feeling. And another point I would like to raise is if there is incongruence between the glucose values and the patient's well-being, then you have to look for diabetes distress, for psychological and psychiatric factors. So patients' glucose levels are very high, right?
Right.
But patient is doing fine. They look for psychosocial things. It might be alcohol. It might be the patient might be on opium. That is quite common in our part of the country. Why is it that the patient is so happy, even though glucose is high for the past 5 years? And opposite also. Patient glucose levels are normal, but patient is unhappy. There's no smile on the patient's face. Find the reason before you move ahead. Don't just, write the same prescription and send the patient back, saying that your sugars are okay, so I don't need to do anything else. You do need to bring the smile back to the patient's face.
Oh, very interesting point, Dr. Kalra. I do not know how many patients, how many doctors actually think to that level, but yeah, that is what is required. If a patient is happy but not happy, but the sugars are bad, look for a reason. If a patients are not happy but the sugars are very good, look for the reason. That's a very interesting way of putting it, sir. Now we have discussed a lot about stress and its effect on the hormones and on the blood sugar. Neha, could you tell us about the importance of sleep now? How important is sleep in diabetes?
Definitely, Dr. Tejal already mentioned sleep is equally important, just like stress, because if sleep is not good, or there is something called a subjective sleep quality, which is related to how you feel you've been sleeping all this while. And another is the objective way in which you assess sleep quality. But the reality is that people hardly know that if they've not been sleeping well, or if they're not getting good quality of sleep, it will definitely be impacting their fasting blood sugar and eventually the overall HbA1c and glycemic control. And stress also has a very strong connection with sleep, because if there are too many, if your mind is preoccupied with a lot of pressing issues, of course, though they will keep running in your mind throughout the day, it'll be cluttered with all of those negative thoughts and overthinking, which will definitely make it difficult for you to sleep. But what happens is that it's a vicious cycle. If you're stressed, or even if you're not stressed, but because of your routine or your hectic work schedules, if you've not been able to sleep well, then it impacts your blood glucose levels, and that further adds more stress to you, that you're not being able to control your diabetes despite doing so much during the day, and hence again you're not able to sleep because of that. So the kind of sleep complaints that we are able to identify are very simple, like not getting enough duration of sleep. So a lot of people are sleeping for less than 6 hours, and they don't know why that is happening, but they don't get enough sleep. Uh, there are a lot of people who struggle to get sleep. While they get onto the bed, they spend time watching YouTube or exploring different gadgets, because they're not getting sleep, and that they don't know that it is further adding on to their sleep issues. That's a different point of discussion altogether. But uh, they are getting troubled for it. Many of them are even taking medicines to get sleep, and people are not able to control or have a good quality of sleep. So if you ask them, they get up frequently at night because of frequent urination, especially when your sugars are not in control. Or sometimes वो कहते हैं कच्ची नींद, जिसमें कि थोड़ा सा भी if there's any noise around you, or if the mattress is not very comfortable, you tend to get disturbed with that sleep. So all these factors are somewhat a part of your normal lifestyle, and people usually don't really take it very seriously. They feel ho jayega manage, but eventually when it continues for a prolonged period of time, you get to see the results, the sleep impacting your overall health. So
Neha,
sleep does have a very direct effect.
yeah, because I'm going to put you in a spot once again, Neha. I have some more data generated by our department, because you have been dealing with thousands of patients in the sleep disorders over the past few years. So I would like to present some data And I would ask you if you could explain this for us, this PSQI index, please.
Currently, I see the diabetes distress scale. I think we need to, this one. So we are using Pittsburgh Sleep Quality Index. It's a standardized test to assess sleep quality, and it assesses various other parameters. So as I said, subjective sleep quality is basically how individually you feel satisfied with the kind of sleep you are getting. And the alarming result is that 76% of people feel that they are not getting good quality of sleep. In addition to that, around 67 people are spending more than 30 minutes on the bed struggling to get sleep. So ideal is that within 30 minutes of you getting onto the bed, you should be able to sleep. And that's not happening. And when people are using gadgets and various other things to spend their time, it is further increasing the sleep latency by almost 1 to 2 hours. So if you go to bed by 11 o'clock, you may not get sleep before 1 or 2. And that's how your entire sleep duration gets affected. Sleep duration, again, people, 44% of them sleeping for less than 6 hours, which is not good, especially in case of diabetes. Research suggests that it should be around 7 to 8 hours of good quality sleep. Habitual sleep efficiency is, again, when people are spending, too much of time on bed but not sleeping. So in Indian households, it's very common to watch TV while you're on the bed, or maybe eat your meal while you're on the bed, or cut vegetables, or even sit with your laptop and work, maybe attend your meetings on the bed. All of this further contributes to poor sleep hygiene, and that leads to further sleep complications, where it is suggested that people should be sleeping only on the bed and doing the rest of the things elsewhere in the house. Can we go on to the next one? Sleep disturbances are also reported by around 84% of people, which include any kind of noise in the environment, or using washroom quite frequently, coughing, or cold, or health-related issues. High stress levels, as I said, stress is again deeply connected with sleep. Tension in your mind, too many negative thoughts, running in your head, not able to make you sleep. So all of this contributes to sleep disturbance, and this is the highest being experienced by people. Around 6% of them are also taking medications, and this is because these people are already going to physicians and doctors, and unless they are recommended by the doctors, they don't opt for such medications. Daytime dysfunction is again very high, 53% of them. So when you're not able to sleep well during the night, you feel a little drowsy or lazy throughout the day. You may end up daydreaming at work, or not able to feel so energetic throughout the day, which is required for you to perform well. So again, your daytime dysfunction is affected because of the poor sleep quality. So we get a global sleep score when we assess the sleep quality through PSQI, and it shows that 77% people are experiencing poor quality of sleep.
I think that's a huge number. 77% of the people are reporting poor quality of sleep. That's a huge number. But Dr. Tejal, I still have a bias in my mind कि ये sleep issues mainly middle-aged या elderly patients में होता होगा. Younger patients में भी ये sleep issues आते हैं. People, younger persons living with diabetes.
I absolutely think so. And I think Neha already mentioned it, right? Most people playing with their mobiles or watching Instagram or something before they go to sleep. We shouldn't talk about personal things, but many people in my family also feel that watching the mobile phone before going to sleep is a way of relaxing before they go to sleep, not understanding that it's actually stimulating them more rather than making them relax. But Dr. Nilesh, I just one comment on the data that you presented and Neha discussed. There's a glaring thing out there that almost everybody is having problems with sleep, but nobody wants to take sleep medications, or very few people are on sleep medications. I want to point that need gap out, because though people are struggling with their sleep, they almost never want to take medications for it. So the thing is that we have to understand that Indian patients do not prefer taking medications to go to sleep. So then we have to devise other ways in which we can help them to improve their sleep hygiene and reduce their stress, because as you could see from the data, the stress and the sleep have a direct correlation with each other. People having negative thoughts, worrying about what happened in the day, worrying about what they have to do the next day, running through lists constantly in their mind. A lot of people commute a lot for work, which adds huge stress to their life. So stress and sleep are completely interlinked. People seem to understand stress effects more than sleep effects, and almost nobody wants to take any kind of medications to help them either cope with their stress or help with their sleep. So there's something else that we need to do for them.
Got it. Acha, just to the audience, Kanika, Prachi, Abhishek, your questions are on hold. We'll take them up, but let us just finish our questions first, and we'll definitely take your questions up. Very interesting questions. The next question was, now, Dr. Kalra, this is for you. How do changes in circadian rhythm and stress affect glycemic control? Now, let's go directly. Okay, we got stress, sleep, circadian rhythm change हुआ है. डायरेक्टली ग्लाइसेमिक कंट्रोल पे कितना फर्क पड़ता है?
काफी फर्क पड़ता है, because the circadian rhythm is a part of physiology. So when you have to work more, you have to exercise more, the active hormones increase. Examples would be growth hormone, cortisol, testosterone, adrenaline, dopamine. And when you relax, when you rest, these come down. It is important to relax and rest and rethink also, because when you're able to give a break to these hormones, they're able to rejuvenate themselves for the next day. Let's take the example of dopamine. Now, dopamine is a catecholamine. Normally, in colloquial language, we would use the words adrenaline and noradrenaline for the catecholamines. But if you look at it from a brain point of view, it's dopamine which is the predominant catecholamine. Dopamine is an adaptive hormone. So when children go for an exam, their dopamine increases, especially if you happen to go for a maths exam. And especially if you happen to be in a webinar where you're being grilled by Dr. Nilesh, then dopamine levels go up. If this happens every now and then, this is adaptive. It's helping you increase your speed. Same thing happens in birds, in migratory birds. When they migrate from Siberia to India, their dopamine levels go up. However, if this dopamine is released in a sustained manner, in a tonic manner, like what will happen if you keep on working 24 hours a day, if you forget the difference between day and night, if you forget to switch off your mobile phones or your work at 10 p.m. or 9 p.m. or 11 p.m., then it's going to work continuously. And then what happens is all the dopamine secreting neurons and also the dopamine receptors, they get fatigued, they get tired, they get desensitized. And this is maladaptive. So let's say you're listening right now, you're a doctor. You do take offs. Even God took an off on Sabbath. Though, of course, there are some people in endocrinology who don't believe in God. That's a separate matter. But still, there was an off taken once a week. If you're a chartered accountant, you audit your funds and your accounts, but you don't audit every day. You audit every month, every 3 months, every year. That's what dopamine does. It will come in every now and then to kickstart your metabolism. That is circadian rhythm. If it's a 24-hour rhythm, it's circadian, but it might be infradian or ultradian. It can be less, it can be more. And when these are followed in a physiological manner, they are all adaptive. But if the environment is created in such a way that it prevents you from following the proper rhythm, then it becomes maladaptive. When it becomes maladaptive, we understand the concept now of quantum entanglement and endocrine entanglement. It's not just a binary or a linear impact that you will have, just sleep, just stress. It's going to impact each and every aspect of your health, your diet, your exercise, and your glucose control.
Got it, sir. Got it. To take this forward, I understand the interdependence between stress and food habits, how they might affect each other. Would sleep also have a measurable impact on your food habits? I mean, if I sleep late or get up early or have poor quality, would it also actually have a direct impact on my food habits or the kind of nutrition I intake? Dr. Kalra, sir, please.
Yeah, it does actually, because there is a time for everything. So now, ideally, what we suggest is a 3+3 meal pattern for everyone, but in practice, it is difficult to follow. What we also advise is that you take relatively more calories during the daytime and relatively less at night. If, however, you are sleeping late hours or you're sleeping irregular hours, what is going to happen is the bulk of your calories are going to be consumed after dinner or in the evening after sunset.
Right.
And the hormones are also wired in such a way. Now, all of us who are here, gathered here, let us say you are given the choice to take murg musallam or to take paneer masala, a very rich, spicy meal. You are given the choice to take it at breakfast or at lunch or at dinner. It's winter time here in the north, and you are given a choice. You will get gajar ka halwa only once. Will you take it at breakfast or at lunch or in the evening? Most of us would bat for evening. We would want to take these heavy meals in the evening. And if you were to be given a simple meal, maybe a boiled egg or just a bread and jam, when would you want to take that? You'd keep that for the morning. You'd park it for the morning. So when you sleep late and when you sleep irregular hours, you end up eating late. You end up eating irregularly. The bulk of the calorie intake goes in the evening, and that is a time when the metabolic rate is a bit slow, and the body is not able to digest it. The body is not able to assimilate all these nutrients and use them up properly, because you're exercising less, you're not going to the gym late night, you're just sleeping. So it does get converted into the wrong things. In my case, it gets converted into fat. And so that is what is that is what actually happens. If you're able to
Right.
sleep regularly, let's say you sleep early, you wake up early, you will find that you will take less of these harmful foods or high calorie dense foods at night. Overall also your intake will come down, and that is why people speak of intermittent fasting these days. But there also, what I feel is we should not be focusing only on fasting. We should be speaking about intermittent fasting, and we should also be speaking about healthy sleeping. If you put them all together, the results are going to be much better than if you focus only on one aspect of lifestyle.
Right. Sir. Dr. Tejal, please add your thoughts, please.
Uh, so the question that you asked was, does sleep have a direct impact on food? Is that correct?
That's correct.
But somehow, yeah, but somehow for me, um, what I find in my practice is stress has a huge impact on the way people eat. Huge
Mhm.
impact, especially in a city like Mumbai. They don't get to eat lunch with their family, and they have a long commute. And then when they come back at the end of the day, there's always a very heavy meal that they eat at night. Also because they've undereaten throughout the day, and they were in meetings, they were stressed, there was no time, they tend to start grazing at night. So I remember this doctor told me that, what I do is, I have my dinner and I go to the clinic. And of course, it's a heavy clinic. He comes home at about 11 or 12 in the night. And then he says, I open the door of my fridge and I eat whatever I can find. So it's ice creams, chocolates, whatever it is he finds in the fridge, he eats. Because running a clinic of 30 people at between 5 to 11 in the night is extremely stressful. Right. So sleep, as sir already explained, does have some impact on food, but I would plump for stress. That stress is an absolute direct impact on food, and I'm sure Neha will agree that food is one of the main coping mechanisms, at least I find in India, for stress management.
Neha, please do comment.
Absolutely true. And I would agree with both the points that sleep also leads to various other food changes, and so does stress. But if we compare the two, then stress does lead to a lot of binge eating or emotional eating, that we say, where people look for solace, or they look for some kind of relief coming from food that they're eating. So a simple example is that if you've had a fight with your boss in office, or the boss ridiculed you in front of 10 more people, it affected you so much. There was no expression that you could of what you were feeling throughout the day. But when you came home, out of desperation, you ordered a pizza and ended up having it because you were so emotionally troubled with the incident which happened. And the only thing that could give you comfort in that moment was the pizza. Whereas if one is not emotionally too overwhelmed, they can still, in a stable mindset, can look for better and healthier options, because here pizza is actually not filling your stomach, it is feeding your emotions for that moment. So these kind of emotional outbursts in terms of food intake we come across very frequently, and eventually these turn into habits when people start getting such food cravings over a period of time, and they are not able to control it at all. And another thing which leads, or continues post this, is the guilt, that now you've eaten it, you've fed your emotions, but it is not still making you feel better, because now you're even feeling more guilty that why did you eat it. So it's again a vicious cycle, and it further keeps increasing your stress and your food habits, and then it impacts your sleep. So now if you've eaten so much throughout the day at whatever time during the day, but it was not healthy for you, it will impact the metabolism of your body in some way. The food may not get properly digested, and that may lead to various sleep issues at night, which will further disturb your next day. So I think all of this is interconnected.
Thank
And
you.
also, can I just comment that when you want to do emotional eating, you usually eat foods which are not high in fiber and protein. So you eat a lot, but you're not yet full. So then you'll eat again. So it further makes it all the more worse.
True. It's a very vicious cycle as such once you get into it. So what I see in the audience is a lot of the doctors agreeing that patients को तो पता नहीं होता importance of sleep and stress. Many fellow doctors also don't know the importance of these in the management of diabetes. So we have a lot of audience agreeing on that. But one particular question by Dr. Prachi is, so okay, how do I differentiate between diabetes stress and general depression? How do I differentiate between the two? If somebody could come in on this.
Neha is the right person to talk about that.
Neha, please.
So I would say that the two things are very different, stress and depression, but there is a very thin line which separates them, because if stress is not managed, it can lead to depression. So stress is an experience in a moment or over a period of time when you are feeling things are going overboard, or they are beyond your control, you're not able to control them, and you're getting a feeling that I'm stuck, I'm not able to move ahead, things are not moving, and I'm not able to find solutions. That's when it's causing stress to you. Now, if this stress and this feeling continues, let's say for a month, 2 months, 3 months, with equal intensity, it can eventually turn into something called depression, which is a feeling of sadness throughout the day. That is the most important thing. You feel so sad that you stop finding pleasure in activities that you usually enjoy doing. It could be driving or reading a book, or maybe reading a newspaper early in the morning while having tea. These are basic activities which people really find pleasurable, but eventually you stop finding pleasure in those activities. Followed by changes in your diet. So you may notice a loss of appetite, or not really feeling the need to eat food. Or, food is there in front of you, but you don't feel like having it. Things like that. So they further add on to various other symptoms of depression. But a thin line which separates the two is, we need to understand the symptomatology in terms of how grave the situation is right now, and what are the symptoms being experienced by the patient at the moment, or maybe in the last 2 weeks, which can help us differentiate whether it is still in a stressful stage or it has turned into a depressive episode.
Thank you, Neha. I have a lot of questions on the audience chat, and I'm tying up 2 questions from the audience with one of my own questions. So we have a question by Dr. Abhishek on YouTube saying that in tier 2 and 3 cities, I mean, it's difficult to get patients to go to a psychologist if they really want to. So what do we do to convince the patients that they really need help in this? Another question by Dr. Yogita on Facebook. She says, long-term diabetic patients don't even understand that they have these issues. Now, if I as a doctor have identified this, how can I help them in such scenario? If I know that my patient is facing stress or sleep issues, how do I help them? These are the 2 questions from the audience. And my own question added to this is, okay, now I've identified these issues in my patients. How do I help them? Are there any solutions in the market? Do you have your own psychologist or nutritionist for your whole practice? Or is there a simple way to help your patients with these kind of issues? Dr. Tejal, I would start with you.
Thank you, Dr. Nilesh. So when you were saying the question out loud, I was thinking in my mind, what do I do in my practice? And I just spoke about this to a couple of friends yesterday. So what I do in my practice is, of course, there is, what can I say? There's a spectrum even of stress and sleep disorders as well. So a lot of times people are going through intense personal stresses, huge events in their life, which are all consuming. In that case, I prefer to refer to an individual psychologist, and there is somebody who I work with very closely who does both in-person and video consults as well, and I refer my patients to her. Whenever I refer my patients to her, I'll write a brief note to her I'll drop her a message explaining to her that what aspect it is that I would like her to address with the person. And we've had huge improvements in people's mental well-being, quality of life, their glycemic control, their adherence to medication, to exercise, as well as to nutrition. So in people who have specific areas of their life where there's maybe a divorce, or the loss of a child, or anything like that, those require more particular attention, and in that an individual psychologist helps. But then there are other people who, as Neha in the diabetes distress scale explained to us, people who struggle with all the demands that diabetes places on you: checking blood sugars, getting the reports done, seeing the doctor, watching what you eat, getting your exercise in. So there are a lot of people who struggle with managing their diabetes, people who are not satisfied with their doctor consultation, and they need to understand how better to approach their doctor when diabetes is affecting their interpersonal relationships. So when diabetes is the crux of the problem, then what I usually do is, and that I refer my patients to the Fitterfly diabetes program, where they have a psychologist, which is an entire team of psychologists who take people through the entire, some people are still struggling with accepting diabetes, then managing their diabetes, the fallout of diabetes. So they do these one-on-one video sessions with the patient. They talk them through all the problems, they understand what it is, and then give them tools to cope with the diabetes. So one-on-one for more particular areas which are not directly related to diabetes. But if it's directly related to diabetes and its impact on the mental well-being, then I usually refer to the Fitterfly program, because I know that my patients will be taken through that whole diabetes journey and will learn ways of how they can better manage their diabetes, how they can cope with their stress, how they can sleep better. So this is what I do in my practice.
Thank you, Dr. Tejal. And Dr. Kalra, how would you manage your patients with these issues, psychosocial issues?
I try my best, and I acknowledge this comment from Dr. Abhishek Deswal. People in tier 2 and 3 cities don't even think about going to the psychologist. And the moment you say that, the patient will walk out of your door. So whatever little help you are going to give the patient, even that is not possible. You've sort of shot yourself in the foot. So what you do is you begin speaking with your patient, listen to your patient also, and most of the patients you can handle. We call it therapy by the ear, Nilesh. So when we speak with younger doctors and we ask them a quiz question, what is diabetes therapy by the ear? So some bright young boy will come up and say, Fitterfly is creating insulin drops to put in the ear. But that's not the right answer. It's actually that you listen to your patient and you speak with your patient in a humane manner. So we practice diabetes therapy by the ear. Sometimes just a little bit of support, comfort, that is enough. If there is a specific thing that the patient needs help with, how to take insulin, how to inject glucose, how to find healthy recipes, how to negotiate with an overbearing spouse or child, how to manage the entire family within a limited budget while ensuring good glucose control, we help with that. Sometimes we are not able to help, and then we do suggest very softly that you can speak to a mental health professional. In my practice, I don't need that all that often. And then there was another comment that there are some people who need medication. They want medication. Dr. 𝗗𝗜𝗔𝗕𝗘𝗣 said that. So if the medication is indicated, the patient has major depressive disorder, certainly we will treat. But if the medication is not indicated, let us say it's just a diabetes distress, then the treatment is coping mechanisms. You have to teach the patient how to cope.
Right.
When we refer to a psychologist or a psychiatrist, don't be very emphatic, and don't unless the patient has suicidal tendencies, this would be an absolute indication for immediate referral. Any kind of suicidal tendency, thought, behavior, refer immediately. Otherwise, you just begin broaching the topic softly. I am trying to give you this medication. This particular medication will help you in neuropathy as well as in mood elevation. In case it doesn't help, we'll refer to you to a person who has more expertise in this particular domain of medicine. So that is the way I go about it.
Great. Thank you, sir. Sir, we're almost out of time, and there are a few general questions which I would rather not take up right now because they're very, very generic, and we have answered them during our talk. So if you have missed, if you don't answer any of your questions, please play this video from the beginning, and you will definitely get your answers over there. So before I wind up, some final thoughts from Neha, Dr. Tejal, and Dr. Kalra. Before, just a few words, and then we can close this. Neha, please, final thoughts.
So I would just say that there is a very strong social stigma attached to meeting a psychologist, and that's why people in not just two-tier cities, but we face this issue in everywhere. In fact, in my 15 years of practice, I've seen this everywhere, that people think twice. They will not think even once before popping a pill, but they will think twice before going to a psychologist. So I would say that a psychologist is a normal human being like any other professional out there, uh, looking forward to help you. And so you just go talk to the psychologist, at least give one chance to yourself to meet a psychologist and talk, express yourself, and then you experience it on your own and see how difficult it is or how socially bothersome it can be. But a psychologist can help you in many ways, in different ways, and help you stay healthy and happy with whatever health condition you may have. So removing the mental taboos associated with it can really benefit people a lot.
Thank you, Neha. Dr. Tejal, please, some final thoughts.
So I beg to differ slightly. I think the change is already coming. A lot of times when I tell my patients that, have you thought of talking to a psychologist? And, they say, yes, doctor, I have been thinking about it. And I was in fact going to ask you that, is it a good idea for me to talk to a counselor or a psychologist? So in the past, yes, there have been a lot of taboos. They may still exist in tier 2, tier 3 cities, but I also think that change is coming. A lot of younger people, middle-aged people are now also becoming open to talk to a therapist or a counselor. And sometimes the hesitancy may come from our side as well, because we assume that the opposite person will not be open to it. So I think at least starting the conversation about seeking help. They may not listen to you the first time, they may not listen to you in the second consultation, but after they've tried everything on their own, and then in spite of that, they'll do meditation, they'll do pranayam, but all of those tools, ways don't teach you how to cope with stress. So then they'll come back and say, what, doctor, you would recommend talking to a counselor, and I would really like to explore that. So I also think that we need to open our minds as doctors. We ourselves need to be more open with referring our patients to psychologists, collaborating with psychologists. And I'm sure that the tide will turn and people will seek help. And ultimately, the reason we're all in this is because we want good outcomes for people with diabetes. We want them to have better HbA1c and less complications. So whatever way we can help our patients achieve that, with medication, with nutritional intervention, with exercise intervention, with sleep intervention, with stress intervention, whatever it takes to get that HbA1c down and have better outcomes, that's what we as doctors should do.
Thank you. And Dr. Kalra, final thoughts.
For persons living with diabetes, do open up with your doctor and speak to your doctor not only about the drugs, the insulins that are being given, but also about your sleep, your diet, your exercise pattern, your stress levels. If you don't tell your doctor, how will she know? For those of us who manage diabetes, ask your patients. If you don't ask them about sleep hygiene, why will they tell you? And for everybody, let's create an ecosystem where we focus more on sleep hygiene. So, sleep hygiene doesn't necessarily mean popping a pill, it means many other things. Stress management, it doesn't mean taking an anti stress pill or just closing your eyes. It means actually learning coping mechanisms. So, let's create an ecosystem where we speak more about this, learn more about this. And I'd like to thank you, Nilesh, for spearheading this conversation. This is the first step towards better health for all of us.
Thank you, sir. I think today we discussed something which was very much in the shadows. And like many doctors said that they knew about it, but they didn't really know how to broach this topic with their patients. So I'm sure we all learned something new over here. I did. And we already have Dr. Anjali saying very excellent speak on discussion by experts. So thank you once again. And before I hand it over to Dr. Rithika, I would like to thank the audience for being here with all of us and thank the panelists. Dr. Rithika, up to you to wrap it up.
Yes, Dr. Nilesh, thank you so much for an insightful and wonderful discussion today. I hope all our doctors will be inspired by the talks that we have had today. we have done today to stress and sleep also. And I would like to thank all the viewers who have joined in for today's discussion. So thank you so much. Thank you so much, everyone.
Thank you, sir. Bye-bye.
Thank you.